really glad to see all of you here for something that talks about exercise. That's a good thing. I just turned 60 this year. My goal has been to continue running into my 60s. Now I've got a new goal. How do I run into my 70s? So I'm glad that Paul is with us this morning to help us on that journey. So Dr. Rud is practicing orthopedic surgery in Brainerd since 1993. He sees patients in Cross Lake on Wednesdays, so sign up for him. And Paul is going to be sharing the benefits of exercise as we grow older. So Paul, thanks for sharing with us today.
Thank you, Pastor. Okay, yeah, I'm also in my 60s, and I don't run. I hate jogging, actually, but I do play basketball. And my goal is to play basketball into my 70s, so we'll see. I just tore a meniscus a couple of weeks ago, but I am playing. I play against 20 and 30-year-olds, so it's kind of fun. I'm going to be talking about the benefits of exercise, but I'm also going to cover a little bit about osteoporosis and falls, and then I don't know exactly how long the talk will take, but then we'll open it up for some questions at the end. So. About 150 years ago, the great Abraham Lincoln gave us a quote that said, "In the end, it's not the years in your life that count, it's the life in your years." If we extrapolate that statement a little bit, I think the statement, exercise puts years on your life and life in your years. That's very, very true. I see dozens of new patients every month, and I've always been struck as I walk into a room and I see the name, I see the age on the chart, and I walk into a room sometimes and the number says 46, and the lady looks old enough to be my mom. But the opposite is also true. I can't believe how many times, especially around here, where I walk into a room and the chart says 92, and I'm looking at this person that looks like they're 70 or 75. So, and I used to always feel, well, that's just really good genetics. And genetics is obviously part of that, but I'm becoming a bigger and bigger believer that it's not just the genetics of it. It's really how active are you? How are you leading your life? The Center for Disease and Control and Prevention, the CDC, has stated that as an older adult, regular exercise is one of the most important things you can do for your health. You know, obviously you can't change your genetic makeup. Your parents are who they were, but you can affect your, are you a smoker? Are you drinking to excess? Are you keeping your weight near your ideal body weight? These are all things that you can do to impact your longevity and your quality of life. About 15, 20 years ago, they did a very large epidemiological study where they took thousands of people and they looked at them and they sort of stratified them into activity levels. And they, anywhere from the couch potato to the person that was getting a lot of exercise. And the findings of that study were striking. They found that in the group that got 150 minutes of moderate exercise per week, they had a longevity that was 7 years longer than the couch potatoes. So out of that study, the CDC made recommendations. They recommend 150 minutes per week of moderate exercise or 75 minutes per week of vigorous exercise. Put that in perspective, that's less than 30 minutes a day. 30-minute moderate walk will, basically has the ability to lengthen your life 7 years on average. It's also important to get strength training, at least two days a week of strength training, and you also need to work on improving your balance. How does exercise lengthen your life? Well, exercise will lower the risk of many of the age-related disorders such as coronary artery disease, diabetes mellitus, certain types of cancer even. Moderate exercise tends to lower your blood pressure, and obviously blood pressure is a very big risk factor for heart disease and stroke. Exercise can reduce the risk of falls and fractures. And really, we have just a looming public health crisis with the number falls and fractures we're seeing in this nation. Exercise can improve your cognitive function, help prevent and delay the onset of dementia, and it helps you stay independent. How do we get started? The older you are, the longer you've sort of been inactive, the more medical problems you have, the more important it is to sit down with your primary care provider and get some guidelines and help. I mean, if you've been really sedentary, you've got some medical problems, you shouldn't be doing this without some advice. A really key thing is to start slow. I mean, you can't go 0 to 60. If you've been sitting on the couch for 5, 10 years, and now you're going to go out and you're going to walk 3 or 4 miles the first day, you know, the next day you're going to be sore and you're going to be regretting it. You might start out with a 15-minute walk or less. I mean, don't go crazy right away. It's really important to set a schedule. Maybe I'm going to do this. I'm going to work out Monday, Wednesday, Friday from 9 to 10. If you're going to go on a vacation, you got to make that part of your schedule. I mean, you know, a lot of vacations you can get walking built into that. Try to work out with a friend or a spouse or somebody. If you've got an exercise buddy, it really helps you keep going. Make sure you're warming up real well before you start and cooling down after you're done. You know, as far as what types of options you have for exercising, probably the best, easiest exercise out there is just simple walking. You know, a moderately brisk walk is considered moderate activity, and 150 minutes of walking in a week supposedly has a huge impact on your longevity. Walking is also good because it's a weight-bearing exercise, and that's going to affect your risk of osteoporosis, and it's simple. Around here, obviously in the winter months, snow and ice, you got to be cautious. Walking indoors, find a place you can, go to your church and walk. We don't have big. My parents lived in Bloomington, so they went to the Mall of America to walk. Swimming is a little bit tough. You got to have a facility, but it's easier on the joints often. The ellipticals are really good. Biking, whether you use a standard bike or a stationary bike. If your balance isn't great, you see more and more people getting these like 3-wheel bikes. Nordic is good. It's kind of a gliding activity similar to cross-country skiing. And then, of course, we've got the racket sports around here. Tennis and pickleball is getting really big. And that's when I play basketball, I'm always the old guy. I rarely play basketball with anybody older than me. But when I go play pickleball, I'm the young guy. So I like being the young guy. As far as the different areas of exercise, so your endurance, your cardiovascular, you're going to get that by raising your heart rate and getting things pumping. Strength training is real important too. Working on balance, just simply standing there on one leg intermittently, just to get those proprioceptive, it's really important to work on your balance. And probably flexibility is the one area of health fitness that we tend to neglect, and the older we get, the more it's just really important to stretch. Sarcopenia, I don't know if you've ever heard that word before. That's basically age-related muscle loss. And, I think we used to think it was really almost inevitable. But, and what are some of the symptoms of sarcopenia? Starting to fall more frequently, muscle weakness, slowed walking speed, difficulty performing your normal activities of daily living. This is not inevitable. I mean, they've done studies recently looking at 80 and 90-year-olds, and you can get good strength gains by weightlifting. Obviously, you're going to start light. I think it's better, when I was playing football in college, we were trying to lift maximum amounts of weights and just doing maybe 3 or 5 times. As we get older, it's better to do multiple repetitions, higher repetitions, lower weight. Let's talk about falls. For people over 65, this is a health problem. 1 in every 4 people over 65 will fall in each calendar year. Of those 1 in 4, 1 in 5 of those falls will cause a serious injury. Every year in the United States, about 3 million people present to the emergency room because of falls. Of those 3 million people, 800,000 of them will be hospitalized. And that thing should say over 300,000 people have hip fractures per year, and that number is going up dramatically. You know, if you look at the sort of the growth curves of people over 80 in this country, it's, you know, we have just so many more people over 80 and over 90 than we did 20, 30 years ago. And the older we get, the more likely we are going to have a fracture. So the numbers of fractures in this company or in this country are reaching sort of epidemic proportions. I've had days where I was on call where I've done 6 hip fractures in one day. And those are major setbacks to your health. The falls are also the most common cause of traumatic brain injuries. And, you know, you can recover from a hip fracture, but you can't always recover from an injured head. In 2015 in the United States, the cost of all these falls we talked about was over $50 billion, and it's going up every year. We can't afford it. Osteoporosis is basically the systemic skeletal disorder characterized by low bone mass, microarchitectural deterioration of the bone tissue, tending to lead to bone fragility and consequent increased risk of fractures. Osteoporosis itself is not symptomatic. You don't know that there's anything wrong until you experience a fracture, and that's the problem. That's why we have to be vigilant. We have to try to prevent the osteoporosis. Heck of a lot easier to prevent osteoporosis than it is to treat it. Once you've had fractures, we're treating you with different medications and such, but it's kind of water over the dam. It's really, it's much better to prevent the fractures. Here's the picture on, I guess it would be your left, is a picture of the sort of the bone of a 52-year-old female, and the one on the right is an 84-year-old female. And you could probably see why the one on the right, if they fell the same, the one on the right was going to break. What are some of the key osteoporosis risk factors? Number one is female sex. Females have much bigger problems with osteoporosis than males. Age, we all lose bone as we get older, and the older we are, the more likely we're going to have a fracture. Race, Caucasian and Oriental people tend to have more problems with osteoporosis than darker-skinned individuals. Smoking is a huge deal. Smoking, everybody knows that smoking might give you lung cancer, it might give you heart disease. It will impact your bone health. And like I no longer do back surgery, but the guys that do back surgery and they do fusions, they will not perform a spine fusion on somebody that smokes, because the numbers are dismal. You can't get the bone to fuse. So smoking is a huge deal with your bone health. Heavy drinking affects your bone health. Really low body weights will lead to osteoporosis. People that undergo bariatric surgery and they lose a tremendous amount of weight, they don't always take in their nutrition the way they should, and they tend to have problems with their osteoporosis. Certain drugs will affect your bone, especially long-term oral steroids. Early menopause, especially if somebody has a hysterectomy early, that can have a major effect on bone quality. Family history, men with low testosterone, and inadequate nutrition are all risk factors. Here's a little chart on your bone. So basically, the blue is men, the pink is female. So we all sort of get to a maximum bone mass around 30 to 40. And that's determined, again, by genetics, activity level, adequate calcium and vitamin D. And what we're finding is a lot of girls and even boys in their teens and 20s are not getting adequate vitamin D and calcium, so they never get to that high peak bone mass. And then when we get to 30 or 40, then we start slowly losing bone over time. You can see men on average are way higher, because when you're getting into here, that's when you're getting more and more fractures. The really steep curve here for the females around 50 correlates with menopause. So most women should be getting DEXA scans, and I hope you've all had DEXA scans, a bone density study. Probably should be starting them around 50. And if there's a strong family history, or you've had a really early menopause for some reason, or there's other factors, consider getting the bone density studies early. Preventing osteoporosis, the number one thing you can do is the adequate vitamin D and calcium. The American diet, most people do not get enough calcium, don't get enough vitamin D. I mean, you don't want to get super physiologic. You don't want to take 4,000 milligrams of calcium a day, but you want to get adequate calcium. Most people say between 1,000 and 1,300 milligrams of calcium is what's adequate. If you're taking, way more than that, you'll actually increase your risk of having some kidney problems, increase your risk of kidney stones. Thank you. Limit your alcohol consumption. Again, do not smoke. This slide is just showing somebody using a cane, somebody using a walker. At some point, from a safety standpoint, we're all going to use a walker, we're all using a cane. Obviously, when somebody is 60, most 60-year-olds don't need to use a walker. Most 100-year-olds use a walker. At some point, you have to decide when am I unstable enough, when is it enough of a threat that I'm going to fall. I probably at least a couple times a month, I have to almost yell at a patient about, you've got to be using a walker. I mean, again, these falls are life-threatening events for people that as we get older. So you're doing your exercise, you're trying to avoid the need for using a walker or a cane, but once you're unstable, use the walker, use the cane, put your pride aside, be safe. As far as a cane goes, a cane is an amazing way to unweight a painful joint. The common mistake that people make is when you use a cane, you should put the cane in the opposite hand of the side that hurts, if you have one side that hurts. Humans walk with a reciprocal gait. We walk like this. So you put the cane in the opposite hand and you sort of unweight yourself. Now, in conclusion, be as active as you can be. I am a firm believer that you will stay young by being active. This is my family here, and this is the old guy and gal here, and these are all the kids and in-laws and girlfriends and boyfriends. So this is what keeps me young. So, any questions? Yes. Uh-huh.
And I exercise 4 days a week with weights. My doctor said what shouldn't I be doing? And I exercise heavy duty.
I think that people that have hip replacements, knee replacements can walk as much as they want. They can bike. I had a guy that he had hip replacement at a very, very young age. He was like 35 when I did it. He had a congenital problem, and he got lost to follow-up, and then he ended up being friends with I've got twin daughters, or they're triplets, but identical daughters, who were friends with his daughter. He came to my house about 10 years after I did his hip replacement and proudly announced that he was running triathlons. No, we don't want you to do that. So I don't think running a jogging program is a good idea for people that have total joints, but certainly you can do all the walking you want. You can do biking. I don't have a problem with my hip and knee patients playing pickleball or tennis. Long distance running is hard on it. I mean, in the older you are, the less you have to protect your total hip. I mean, I tell people when I'm going to put a total knee in, it's like any kind of a mechanical implement. It's metal and plastic. So many cycles it's going to wear out. If I got a guy that's 6'4", 250 pounds, and he's 55 years old, I'm concerned that guy's going to wear that total joint out. And I don't want him running. But if you're 85 years old and you're 140 pounds and you're not that strong, you're probably not going to wear that hip out. So I think you can exercise as much as you want.
Well, I go to an exercise class and we use weights. I was told not to go too much on either side. Is that true?
Some weightlifting can be hard on the shoulders, but generally, I'm not worried about like your hips in the weightlifting. No, I think it'd be hard for you to overdo it on your hips from weightlifting. Question?
I stopped taking calcium a number of years ago. I do take vitamin D, and I have osteopenia. The reason I quit is because there was information out there
Oh.
that too much calcium can harm the heart.
I'm not aware of that, and I'm not a cardiologist. I know that they do calcium scoring. When you're looking for heart disease, you can have a scan, and it'll show calcification in the blood vessels as a sign of cardiac disease. But I've never actually read that. I mean, I think the main concerns I read about as far as too much calcium is the kidneys and kidney stones. So I guess I'm not aware of that. You could check with your primary care provider, but I think you not getting enough calcium with the fact that you've already got osteopenia is a bigger threat to you than taking a little. I mean, I wouldn't take more than, the average American diet gets about 600 milligrams of calcium. So if you have a fairly normal diet, I would try to supplement with about 600 milligrams, like 3 Tums. But I wouldn't supplement with 3,000 milligrams or anything. But I think it's important for you to take it.
And my bone density has stabilized since due to celiac, went gluten-free. Maybe the exercising helps too.
The weight bearing, walking is great. I mean, biking is a great aerobic exercise. It's great for your heart. Biking is not as good for your bones. Swimming is the same thing. Swimming is a great aerobic exercise, but it's not loading your bones. Walking is a great exercise as far as every time I do that. When you exercise a muscle, your muscle gets bigger. When you exercise bone gets stronger. It's called Wolff's Law. So, yes.
How often are you supposed to have an DEXA scan after 50?
That's a good question because insurance won't always cover it very often. I think you can probably get every 5 to 10 years, but every insurance is different. I think if you've been found to be osteopenic or osteoporotic, it's more likely you can get it more often. And that's probably a better question for your primary care provider. They'll know. Unfortunately, so much of what we do medically now isn't determined by what the doctor thinks is right. It's what does the insurance company think? So, question.
How do you think chiropractic can fit into this?
I'm a big believer in chiropractics as far as, some orthopedic surgeons really think like they're over here, we're over here, and we can't really cooperate. We have a really good chiropractic community in the Brainerd Lakes area, and working with the chiropractor to keep yourself moving if it works for you, great. Yes?
Mine was kind of similar to the calcium, because they wanted to do an infusion, and I thought, I drank milk all my life. But anyways, then another doctor told me instead of the calcium, K2. He went to some convention.
When you were talking the infusion, were you talking an infusion of a drug to help the calcium, probably bisphosphonates? Yeah. So when you've been diagnosed with osteopenia or osteoporosis, the number one class of drugs that's been shown to sort of halt or slow down the loss of bone or even bring some bone back are the bisphosphonates. And some of those are oral pills. Some of them there's one that's every 3 months. There's one that's once a year. Some side effects with it, but if you've got osteopenia or osteoporosis, they usually want to. So the infusion was probably not a calcium infusion. It was probably a bisphosphonate infusion. Yes?
So what is the difference between osteopenia and osteoporosis?
when you're looking at a DEXA scan, the reading on a DEXA scan will give osteopenia is less severe. You're 1.5 standard deviations below the mean compared to an average young adult. Osteoporosis on a DEXA scan is your 2.5 standard deviations below the mean or more. Technically, osteopenia and osteoporosis are a little bit different, but in the realm of the DEXA scan, it's just osteopenia is less severe, osteoporosis is more severe. So, any other questions? Yes?
You didn't have running on your list of good exercise? Is that because of the jarring?
Yeah, I think maybe because I hate running. No. I think that if you don't have any significant musculoskeletal problems, knee arthritis, hip arthritis, back problems, I'm fine with people running. I think it's hard for somebody over 65 to take up running, but it's certainly, if it's, and again, start really slow and you can try it. I would say that walking, biking, elliptical are going to be tolerated better than running. But there are certainly people over 70 that run, and if you tolerate it, I think it's fine. I think everything, when you're looking at an exercise program, it's a little bit of a trial and error thing. I mean, biking might be great for you, and biking might bother you. I mean, what works for me? You know, the important thing is find something that you can do to keep your activity level up. For most people, the most universal one is walking, excuse me, but really find what works for you. Yes.
Can you talk a little bit more about vitamin D? Like what should people supplement with? Like my understanding is that, you know, in this area, everybody should probably be taking a vitamin D supplement, and how much?
Yeah, absolutely. And it really depends on the time of the year. So what she's getting at is vitamin D, you get that naturally with sun exposure. So, you know, most people in Minnesota from, well, this year, May or June. So most people in Minnesota from May to June to, you know, August, September, maybe they don't need to take vitamin D supplementation. In the winter months, 400 to 800 milligram, or international units, I guess, is you know, supplement in the winter for sure. I was surprised because I go and do my yearly physical in a couple of years, and I love the sun. I get out in the sun, I get all tan all summer. But I went in for a yearly physical in like February, and I got tested, and my vitamin D level was low. So I do supplement. I just take a multivitamin, and there's pretty good amount of vitamin D in the multivitamin.
I think there are some differences between, like, my understanding is that functionally, you really should be better than 50 for your vitamin D level.
Yeah, and I can't speak to the detail. You know, there's a range. You know what is normal. I was like right in the low normal. I think I was in the 20s. I think you don't need to be off the chart. If you take too much vitamin D, you tend to just kind of pee it out anyways. So you can cheat up. It's not like, I think there's probably less harm with taking a little extra vitamin D than there is taking too much calcium. But I think we should all supplement in the winter here. Yes?
I had started taking vitamin D because someone had said that you should take it in the wintertime. When I went to my doctor for my physical, she actually was able to get a vitamin D test, and she said, you do not want to be taking that every day. You want to take it every other day, that's going to be plenty for you.
So you had good vitamin D levels then, yeah. Most of us, unfortunately, are not getting that, is what we're finding, though. But I think, oh, yeah, way in the back? Yes. It's a blood test. I mean, and we all do have declining levels of testosterone, us men, as we get older. But there's there's a certain level of decline that's normal, and if you're declining even more than normal, then they call that low T, and there is supplementation for that. And so that's something that if you're concerned about it, I don't think it's a routine test on your yearly physical, but it's certainly something you could request. So, yes, way in the back.
How do you feel about collagen as a supplement?
You know, there's a huge industry of supplements, and so many of them we don't really have a whole lot of data to say yes or no. As far as supplements go, the supplements I'm the most familiar with as far as any data on them is glucosamine sulfate, chondroitin sulfate, which sometimes came from shark cartilage. That one, there's actually been some studies, and again, there's conflicting studies, but the study that I'm the most familiar with looked at, you know, they took a large group of people that had lower extremity pain complaints and arthritis, and they gave half of them sugar pills, and they gave half of them glucosamine chondroitin sulfate, and what they found was that the people that got the real pills were much more likely to say they felt better. Doesn't tell us why or how or anything. I'm not that familiar with using collagen as a supplement. There's more and more people saying they feel better when they take turmeric. I think so. I think you're going to hear more and more about supplements as time goes on. I think that that right now it's to be determined, is what I would tell you. Any other? Oh, right in the middle.
This is a little off the subject, but how do you feel about a memory supplement?
Yeah, I've seen the ads. Have no idea. So I'm a little bit of a skeptic when I'm watching TV or listening to radio, and I hear, you know, pretty sensational claims about this or that. I guess I'm more show me the science. So, you know, if you're buying a supplement, A, don't spend too much money on it. B, try to make sure you can figure out that there's not a side effect risk. So I wouldn't spend $200 on some supplement because some Billy Bob at the circus told you that it's going to make you feel better. You know. So I think there's not a ton of data to support stuff like that. So yes.
Chewing tobacco, is that as bad for?
I don't believe that that's likely as bad for your bone health. It's gonna. Oh, I hope that I'm not making somebody next to you squirm here. It's bad for oral cancer risk. You know, that's the biggest issue with chewing tobacco is, you know, mouth cancers. But I'm not aware of data that says chewing tobacco would affect your bone health. I think it's I think it's the inhalation and the I don't know for sure though, to be honest. Yes.
What effect does obesity have on your joints and your bones? I noticed every booth here had candy.
And I enjoyed it. Obesity has a huge effect on the joints. When you're walking down the street, your knee actually sees 3 to 5 times your body weight. When you're running or you're going up and down stairs, your knee sees 8 times body weight. So I'm trying to lose 10 pounds off my gut. If I lose 10 pounds, my mildly arthritic knee will see 80 pounds less per square inch of pressure. So I think, obesity is really bad on the knees and the hips and the ankles. It's really hard on your back. It's really hard. It's hard on the heart. So I mean, we all like to eat, but I think if you exercise more, you can eat more. You know, I think it's a matter of input and output. So if you love to eat, like a lot of us do, the more active you are, the more you can eat without putting on excess weight. So maybe a happy medium. Exercise a little more, eat a little less, and lose that weight. But so obesity clearly has a major effect on orthopedics. And we're getting to the point now where At some point, we probably won't be allowed to do a total knee or a total hip on people above a certain BMI. BMI is a measure of how heavy you are in relationship to your height. Because we have hard, fast data that shows that if your BMI is above a certain amount, your risk of complications, objective risk of complications in the operation is significantly higher. Increased risk of infection, increased risk of blood clots, increased risk of malpositioning the cup. I mean, if I'm operating through 6 inches of fat, it's hard for me to put the knee or the hip in the right position because all that you can't get the fat out of the way. Operating on a skinny knee and a person that's at their ideal body weight is a heck of a lot easier than operating on a leg that's bigger around than my waist. So obesity is definitely something we struggle with. Yes?
Does muscle weigh more than fat?
Yes. I mean, I don't probably look like I'm morbidly obese, but I'm considered obese because muscle does weigh more than fat.
Like how much?
I can't tell the exact, grams per unit area, but muscular people weigh a lot. And I will tell you that the morbidly obese people we work on, once you get below the fat, most morbidly obese people are incredibly strong because you got to be to carry all that weight. There's a lot of muscle in usually there's a lot of muscle buried underneath that fat, but yeah, muscle is heavy.
So when they say you should weigh this much for your height,
That's a rough guideline because again, I'm a little bit overweight in my tummy. I'm markedly overweight according to the graphs, but I'm actually pretty strong for my age. So muscle does weigh more than fat. So when you look at these graphs and stuff, it's a guideline because some people are just bone, they're just naturally really slender and they don't have much muscle. They're going to be considered underweight when maybe they're not. Some people are naturally muscular and there's there's some bodybuilders that are like, they have zero. You've seen the pictures of the guys that are on, they're not healthy because they're usually on steroids, but they're just muscle upon muscle upon muscle. They don't have an ounce of fat on their body, but they would be listed as being morbidly obese because of their weight compared to their height, and they're not obese. So, any other questions? Okay, well, thank you for your attention.